3 and 4. Okay? Any questions? Yes.
So the 50 was for what?
PCO2, greater than 50, or 50 or greater. That's ventilatory failure or respiratory acidosis, hypoventilation. Okay? Has nothing to do with number 1 at all. Number 5, the responsibility of the lungs is to excrete CO2, while the kidneys are responsible for excreting fixed acids, so the correct answer is C. The lungs cannot excrete anything else but CO2. It was only one answer that was possibly correct. Number 6, interpret the following. pH 7.50, PCO2 is 28, which is acute respiratory alkalosis. But we got a PO2 there of 62, and that's hypoxemia. The correct answer is A, respiratory insufficiency. Any questions? No questions? Okay. Number 7, which of the following terms is synonymous for a chronic acid-base condition? The answer is D, compensated. Number 8, which of the following is a synonymous term for an acute condition? The answer is C, uncompensated. Any questions on page 1?
Ms. Moore,
Ebony, I'm sorry. Who's talking?
For number 7, you circled C.
I did?
Yeah.
Okay, just give it back to me. That's not here.
That's okay.
Okay. I'll change it.
No,
I just wanted to see if you were on your toes. Yes.
I'm sorry, can we go to number 6?
What about it?
For respiratory insufficiency, the determinant has to be that its saturation is low.
No, the TO2 is low. We don't have a saturation on here.
Right, but I thought with PaO2 being low, that was for hypoxemia.
That is hypoxemia. And when you have respiratory alkalosis with hypoxemia, that is respiratory insufficiency.
Thank you.
You don't need a SAT to determine hypoxemia. You need a SAT to determine tissue hypoxia.
Right, okay, see, I was confused. I just thought that the saturation was, I needed to see it, but if the PaO2 is low, then.
You can't ignore it.
Okay.
So that's why C is not correct, because it doesn't have with hypoxemia on it. It's not a complete blood gas interpretation. See it?
Maybe I'm just overthinking it.
I don't know.
So just if it had hypoxemia, was it? I read it, I just thought it was, I read it just as.
You can't. No.
So you don't?
No.
Okay.
You got a PO2.
Okay.
Okay, yeah. Okay, any other questions on page 1? Yes, ma'am.
So wait a second. Did she say
Partially
7
compensated,
is
the pH
what?
is not
C?
within
Or
range.
7 is D?
Compensated, the pH is within range.
Okay, she left that alone. And then, but what was? Okay, so she.
You need to speak up.
Oh, okay.
Chronic
All right.
acid-base conditions, the pH is
Yeah.
within range.
Yes.
So it's D.
Any other questions on page 1?
Because remember, chronic and compensated, C and
1
C.
through 8. Any questions? Okay, let's start on number 9, page 2. A patient enters the ICU with the diagnosis of oxygen-induced hypoventilation. You know what that means. You need to know what that means. Which of the following terms apply? The patient has a decreased minute ventilation? Yes. The patient is a CO2 retainer? Yes. The patient is experiencing hypercarbia? Yes. Chronic metabolic acidosis doesn't have anything to do with oxygen-induced hypoventilation. So the correct answer is C, 1, 2, and 3. Any questions? Okay, number 10. A lot of you bombed out on this. And this is what you need to know. This is how I know, and you know. These are things you need to know. Number one, if the base excess is increased, where is the bicarb standing? If the base excess is increased, then the bicarb has to be increased, right?
Correct.
Right.
When you have increased bicarb, what is that?
Base.
Metabolic alkalosis.
Mhm.
Real simple. So the correct answer is what?
A.
A. Everybody didn't get that. What?
Oh, you're on 9 or 10, man?
I'm on 10.
Okay, sorry.
The pH is increased, that's alkalosis. The base excess is increased. The base excess must match the bicarb. So you have metabolic alkalosis right in front of you. Any questions? This is how you have to critically think. This is how we see things 2, 3-dimensional. Does this make sense now? Some got it right, but not enough. And I don't know why. So you need to ask me questions, or do you see your error? The rule, whatever the bicarb is doing, that's what the base excess will do. And I told you, you don't need a bicarb. If you have a base excess, and in this case you have a pH, you can make the call what it is. And the answer for 10 is A. Does everybody understand that? Okay. So quite often I'm going to ask you or give you statements without numbers. And that's why I said when you get a quiz or get a test, make your little cheat sheet, whatever you need. So you can see this if you still can't figure out what's going on. Okay, so number 11. During chronic ventilatory failure, so what does chronic mean?
Compensated.
Okay, it means compensated, or the pH is going to be normal, right? So we can rule out D right there. All right. So during chronic ventilatory failure, a lot of you got this wrong. The PCO2 is what?
Increase.
Increased, because we're dealing with ventilatory failure. So we got a normal pH. We got an increased PaCO2. And so what compensated for this increased PCO2?
Bicarb.
And is it elevated or decreased?
It's increased.
It's increased to make it a base. A lot of you got this wrong. The bicarb is not decreased, because then that would not be a compensated blood gas. It would be mixed acidosis. The correct answer is A. Bicarb is not decreased. When the bicarb is decreased, now you got metabolic acidosis, and that's not the case here, right? You got a normal pH, which is a compensated blood gas. You got opposite conditions. If it's ventilatory failure, this is acid. And if it's compensation, the base has to be opposite to offset to make this pH normal. So the primary problem is respiratory acidosis. The compensatory factor or mechanism is the metabolic alkalosis. So again, the correct answer is A. Any questions? Okay. Number 12. Which of the following represent the 2 ways oxygen is carried in the body? Definitely number 1. And number 2 and 3 are the same thing. Oxyhemoglobin is represented by the value of SaO2 in a blood gas. PCO2 absolutely has nothing to do with oxygenation. That's ventilation. So the correct answer is C, 1, 2, and 3. Any questions? Okay. Clinical data pertains to number 13 and 15. Here's a blood gas, and the doctor needs your assistance. pH 7.29, PCO2 67, PO2 58, bicarb 24, base excess normal, sat a little low, and then I threw in hemoglobin, which is normal. Okay. So which of the following interpretations are applicable? Acute respiratory acidosis? Yes. I see an acid pH and I see an acid PCO2. Everybody see that? Okay. Chronic renal failure? No. Number one, it's not chronic because the pH is not within normal range. And number two, the bicarb is normal. Yes? All right. Partially compensated blood gas? No, it's not partially compensated because if it was partially compensated, that bicarb would begin to become alkalotic. Yes? All right. And then acute respiratory failure? Yes, there's my 50-60 rule. I have a PCO2 greater than 50. Yes? And I have a PO2 less than 60. So the correct answer is B, 1 and 4. Any questions? Okay. You all are awfully quiet. Yeah.
Respiratory failure and ventilatory failure is the same thing?
No. Ventilatory failure is respiratory acidosis. Respiratory failure is respiratory acidosis with hypoxemia. And you got a PO2 well less than normal here. See it? Okay. All right, number 14. Which of the following are applicable? This stump, you guys. This PO2 of 58. Peripheral chemoreceptors have kicked in. First compensatory response to peripheral chemoreceptors kicking in is tachycardia. Yes?
Yeah.
Okay. Second response is hyperpnea or tachypnea, as you all want to say tachypnea, but tachypnea. And then the third response is pulmonary vasoconstriction. So the correct answer is C, 1, 2, and 3. Critical thinking. You got to go back to look at PO2, and you have to know peripheral chemoreceptors have kicked in. Got it? Any questions?
Tachycardia, peripheral chemoreceptors.
In this case, that's the first response. Whenever a patient is breathing off their hypoxic drive, the first physiological response in the body is tachycardia. The second, increased respiratory rate. The third is pulmonary vasoconstriction because they are hypoxemic. And all three of them are there. What's not here? What else happens that I don't have on
Oh,
here?
cold and clammy.
The diaphoresis.
Yeah.
So the correct answer is C, 1, 2, and 3.
Do we just automatically know that?
You know that as a therapist. You have to know a PO2 less than 60, what happens? There it is, 1, 2, and 3. Okay, number 15. Some of you kind of didn't get this one, but it'll make sense. Study this quiz, because this is blood gases. It's just not numbers. It's understanding what caused the numbers, or it's understanding what happens after these numbers occur. In order for complete compensation to occur, number one, what does compensation mean?
pH is normal.
pH is normal. So one answer is with a 3 in it. Right? The pH will be within normal range. That's one of the answers. Does that make sense? Because it says compensation. Now, this is respiratory acidosis. I asked the same 3 times on this quiz. If you have respiratory acidosis, what has to compensate for it? Metabolic alkalosis. So the bicarb will increase. The correct answer is A. 3 and 4. Any questions? Come on, ask questions. Somebody should be asking questions.
I have a question.
Yes. I'm listening.
I'm sorry, on number 15 with the bicarb increasing, that's within normal range already. The 24, it still would increase?
It has to. If the
Okay.
compensation is going to occur, look at the question.
Yeah, it's gonna go higher.
Okay.
The blood gas, excuse me, I have
Be out of the normal range to compensate.
the blood gas is in, the patient is in respiratory acidosis. I got it right here. If compensation, what's going to have to occur? The pH has to be normal and the bicarb will have to elevate for it to be compensated respiratory acidosis.
Okay. It threw me because it was within normal range, that's all.
Well, that is, a pH within normal range is a compensated blood gas.
No, I know.
Any questions? Okay. You'll take another one next Monday. Keep these, study them.
Ms. Miller, do you want mine back?
Yeah, give me yours. I'll give it to you in the morning. Now, what you need to understand, now I'm going to give you blood gases with the PO2 in it, and if that PO2 is less than 80, you're going to tell me it's hypoxemic, but if that PO2 is 60 or less, and I ask about what's happening, you can't ignore. You've got to understand that the peripheral chemoreceptors have kicked in. And I may not ask you about a peripheral chemoreceptor, but I'm going to continuously ask you about tachycardia. Okay? Or if you have a case scenario like the little man yesterday in pharmacology, his heart rate was 108. His heart rate was 108, not because he had cardiac problems, but because he was hypoxemic. And we didn't even have a blood gas. But he had excessive secretions in his lungs, remember?
Yes.
And those excessive secretions interfered with gas exchange. So even without having a blood gas, I know this man was experiencing hypoxemia, and I know the first response to hypoxemia is tachycardia, right? I know the second response, the patient's patient's respiratory rate is going to increase, right? And you're going to see that. You're going to actually see it in clinical. So this is how you know blood gases. And we're not done by any means, but keep working at it, okay? You sure you don't have any questions? Because we're still in module 2. Okay, we finished low gas flow system. Any questions about low gas flow systems, O2 toxicity? Yes.
Low gas flow systems are variable, so you can't give a specific percentage of FiO2.
Yes, ma'am. It's dependent upon the patient's minute ventilation. You are correct. We only have a range.
Would you ever have a situation where you actually needed to give only a specific?
Absolutely, a CO2 retainer.
Okay.
Any patient that comes in oxygen-induced hypoventilation, I've never mentioned pathophysiology, but another type of patient like that would be OSA, obstructive sleep apnea patients. When they're asleep, they have a tendency to retain CO2. You don't give them high concentrations because you'll knock out their hypoxic drive. Absolutely. Any kind of patient dealing with oxygen-induced hypoventilation, CO2 retainers are not the only type, but for now, that's all I want you to know. Absolutely, yes.
And you said COPD patients are the only CO2 retainers we're going to come across, or is there another?
No,
other?
no,
there's-
no, no, no,
okay,
no,
so
no,
there's
no, no,
more?
no, 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 no,
Okay.
there's others, no,
Okay.
but right
That's the
now,
only one
that's
we
all
got.
we're going
So we
over.
need to know, okay.
Yeah, when we get into pathophysiology, we'll learn about
Okay.
others.
I just couldn't figure it was just one group.
Oh, no, oh, no. Yes,
Just to clear, cyanosis of the patient poses also another physiological effect of a patient that has respiratory acidosis with hypoxemia.
no, 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 no. Cyanosis only is dealing with oxygenation. Everybody who may be experiencing cyanosis may not have a ventilation problem.
Okay,
Cyanosis is an indication of tissue hypoxia.
okay.
And by definition of cyanosis is decreased hemoglobin by 5 grams per cent. Okay? So everybody who's cyanotic may not have a problem with ventilation. Cyanosis is solely an indication for oxygenation.
It's like hypothermia, right? You see things that their limbs turn blue and all that, and that's
Yeah.
because they're not getting oxygen to tissue because their body's shutting down, not because they're having it's still a
Well,
ventilation problem, right?
right, yeah.
Turning blue's got absolutely nothing to do with being depressed at all.
Being depressed where?
You got the blues, that,
No, it doesn't. All right, so no questions, I'm moving on. Oh, I did it right. Okay. Where are we now? High gas flow systems. It's going to be more math, more pain for you. Okay, high gas flow systems. High gas flow systems provide an O2 concentration and total flow. So when we talk about high gas flow systems, the definition, number one, it does two things. With a high gas flow system, as Catherine asked, a high gas flow system can provide a specific FiO2. And also a high gas flow system provides a total flow. And when I say total flow, we can have our flow meter set at 15 liters per minute, but that's not the only flow that the patient is receiving. And most of the time, when we set up a total flow gas system, that device provides all of the patient flow for the patient. Whereas a low gas flow system, we know where they're getting some oxygen. We perhaps have a range, but we really don't know because it's based on their minute ventilation, right? Yes. Now, with the high gas flow system, most of the time, not all the time, the patient is breathing spontaneously. A high gas flow system where a patient wouldn't be breathing spontaneously is a mechanical ventilator. So we're not going to deal with that right now. So the patients that we're dealing with right now are breathing, but with a high gas flow system, they can get a specific FiO2 from the apparatus that we set them up on, as well as total flow. That's the difference, yes.
When you say apparatus, do you mean?
It's different apparatuses. When we get to them, I'll tell you what they are. What's your question?
Do you mean the device or the mask?
Apparatus, device, mask, whatever you want to call it. All of them are not masks. When we get to it, I'll tell you what they are. Okay. Patient's inspiratory demand, that's flow. How much air the patient needs on inspiration. Now, we're all breathing normal, yes?
Yes.
Let's say we have an asthmatic, right? And they're experiencing bronchoconstrictions. When are they first going to use their accessory muscles, inspiration or expiration? Expiration. Okay, they've decided for whatever reason they didn't come to ER. Now they're struggling on inspiration. And how we'll see that, they'll have an increased work of breathing. Yes? Okay. So maybe before they were experiencing bronchospasms, I'm just picking a number, don't ask me how I got it, based on tidal volume respiratory rate, maybe their minute ventilation was 5 liters per minute. But now, because they're having an increased work of breathing, their respiratory rate has increased, and now their minute ventilation has increased to 12. okay? So their minute ventilation has increased to 12, so they're going to breathe harder to get the air in, okay? So that's inspiratory flow, and it's in liters per minute. It's time. Everybody understand that? It's time. So how do we find inspiratory flow? Well, what you do, a quick way, you take your minute ventilation and multiply it by 3. Have you all learned how to calculate tidal volume yet?
Yeah.
Okay, what's the formula for tidal volume for someone spontaneously breathing? I said, what's the formula for tidal volume?
Oh. It's minute ventilation over respiratory rate?
Minute ventilation is tidal volume times respiratory rate. I'm asking about tidal volume. Well, before I ask for the formula, what's the definition of tidal volume?
what you can take in
What
one
you can
breath.
take in
It's
one breath.
anatomical dead space plus alveolar ventilation.
That's tidal volume. That's the formula.
Yeah.
What's the definition of tidal volume?
The amount of air.
Just meant like one.
The amount of air, who said it back here? The amount of air, inhale, exhale, in one breath.
One.
All right. How do we calculate tidal volume?
Anatomical dead space plus.
Nope. It has to do with weight. We can calculate tidal volume in pounds or kilograms.
1 millimeter per 1 pound.
That's anatomical dead space. Okay. The formula for tidal volume, 3 to 4 milliliters for a pound. Oh, yeah. 3 to 4 milliliters per pound of body weight. Or what's the other one?
5 to 7.
5 to 7 in
7.
kilograms. Okay. So write your weight down. This is a secret. You don't have to share this with anybody.
Thank you.
Write your weight down in pounds. Now, I want you to calculate your minimum tidal volume. So your minimum tidal volume will be your weight times 3. Do the math. And that's your tidal volume. Now do your maximum tidal volume. Take your weight and multiply it by 4. And remember, if it's less than a liter, it's in milliliters, right? All right. So everybody got a range now. You see your range for your tidal volume based on your weight. So actually, that's a quick way. Tidal volume really depends upon your weight, your height, and a few other factors, but for now, that would be okay. All right, now, you got your weight. Yes? And somebody, 2 or 3 people told me about anatomical dead space. How do we calculate anatomical dead space?
That's our weight in milliliters.
That's your weight in milliliters, right? Okay. So take your maximum tidal volume, which you just calculated. Everybody's answer will be different, yes? All right. And subtract your anatomical dead space. Subtract your anatomical dead space. Everybody got an answer?
Mm-hmm.
Okay, and what is that answer?
Your minimum.
Absolutely not.
Mm-hmm.
What's that answer?
Alveolar.
Alveolar
Alveolar.
ventilation. Right.
Mine came out as.
So did mine.
Okay, so your tidal volume consists of 2 parts, right?
Mm-hmm.
Anatomical dead space, that part of your tidal volume that's not involved in gas exchange, right? What purpose does dead space, anatomical dead space serve? If it's not involved in gas exchange, what purpose does it serve?
Well, it helps keep the alveolar inflated for one thing.
It keeps the alveoli and your airways open on expiration, right?
Right.
All right. And then your alveolar ventilation is that part of your tidal volume that is involved in gas exchange, yes?
Yes.
Mm-hmm.
All right. Any questions with that? It's two parts to a tidal volume. Number one, your anatomical dead space that's not involved in gas exchange. It's about 1/3 of your tidal volume. Any questions with that? Yes.
So your minute ventilation times 3.
Flow. I've had to back up because you all can answer my questions. So before we go there, I had to provide clarity. It's no sense in me talking about flow and total flow and you all don't know what a tidal volume is. So I had to back up. Okay, we'll get there. All right. So 1/3 of your tidal volume is anatomical dead space. Yes? And it's not involved in gas exchange. 2/3 of your tidal volume is called alveolar ventilation, and that's the portion that's involved in external respiration. Does that make sense?
Yes.
All right. So if I ask you about a tidal volume, you should be able to tell me and anybody. It's 2 parts to a tidal volume. 1 part or 1/3 that's not involved in gas exchange, which is anatomical dead space. Go back to chapter 2, cardiopulmonary A&P. And 2/3 that's directly involved in gas exchange, and that's called alveolar ventilation. Right? Any questions with that? So essentially what this is saying, even though we take in a certain amount of air each breath, all of that air is not directly involved in gas exchange. It is not. Because we have to have some remaining in our airway when we exhale so that our lungs and our airways won't collapse on expiration. So it doesn't matter how hard we exhale, like say we're blowing out candles on a birthday cake, we still should always have some air left in our lungs. Does that make sense? So it's 2 parts of a tidal volume. How do we calculate tidal volume? You have to know the pounds, the 3 to 4 milliliters per pound, or you have to know how to do it in kilograms, and you all said 5 to 7, right?
Yes.
All right, so let's go through the kilograms. You got your weight, you wrote it down, it's a secret. How are we going to convert it to kilograms?
Multiplied by 2.2.
If you multiply by 2.2,
Divided by
your
2.2.
kilograms are multiplied by 2.2.
Yeah, if it's starting in kilograms, she was multiplied by 2.2.
It's multiplied by
We're starting in
2.2.
pounds. How you going to get to kilograms?
Oh, divided by, I'm sorry, 2.2. Right.
Take your weight and divide by 2.2. Everybody got an answer?
Mhm.
And that is your weight in kilograms. Everybody with me? If you're not with us, let me know because we're moving on. Okay, now you got your weight in kilograms. Calculate your minimum tidal volume. Minimum, you said 5 to 7. Minimal is use the 5. Take your weight in kilograms and multiply it by 5. Bless you. Everybody got an answer?
Mhm.
Say yes. Tell me no if you don't.
Yes.
Oh, okay. Good. Now, take your weight, your secret, in kilograms and multiply it by the 7 for your maximum tidal volume. Now you see the difference between the two ranges? They should be somewhere close together. If you use the 3 to 4 milliliters per pound, you'll have a range. And then you should have another range, maybe a little bit more, when you use 5 to 7 based on kilograms, right? But all of it should be in a range. That's a range, meaning not exactly every breath is going to be the same, but based on your weight, you should ventilate. Your tidal volume each time you breathe should be somewhere within those ranges, right? All right. So you've got to be careful if I or Miss Sharkana gives you a weight in kilograms. You can calculate the tidal volume, but you can't calculate the anatomical dead space in kilograms. That's when you need to multiply it by 2.2. So let's do this. You have a patient who weighs 50 kilograms. 50 kilograms. Calculate the patient's maximum tidal volume. They weigh 50 kilograms. What's the answer? 350. Everybody got 350? How'd you get 350? 50 times 7. That's the maximum tidal volume, right? Everybody with me?
Yeah.
Now calculate the patient's anatomical dead space.
110.
How'd you get 110? 50 times what?
2.2.
Okay, now what's the patient's alveolar ventilation? Alveolar ventilation. 350 minus 110. 240. Everybody got that? Okay. Yes.
Now, what happens if we, instead of just doing the kilograms, we
Hold on,
convert-
it's a question over here I can't hear. Go ahead.
So, the way I went about it was I did the conversion first.
That's what I did.
And then multiplied it by 4, so we're gonna get like a different number.
Tell me, I hear you, but I don't know what you're asking me.
Okay, so you gave us 50 kilograms.
Yes.
And we could just multiply that by 7 to get the maximum tidal volume.
Yes.
But like, if we go about it differently and we convert to pounds first and then
You
multiply
have to
by
be
4.
careful. If I ask for the maximum tidal volume in kilograms, you
Okay.
cannot convert
Do
it.
not convert.
You cannot convert it. You got to use the 5 to 7.
Okay.
All right? If I ask for maximum tidal volume in kilograms, you cannot convert.
But if you ask for it in liters, then.
But if I give you 50 kilograms and I ask for the minimum tidal volume in pounds, that's when you convert.
Okay, so pay attention.
You've got to pay attention to what's being asked. Make sense?
It does.
Okay, yes.
Okay, and when you're doing the conversion, like I did here, like I did the 190 or whatever it was, and I got that, what unit?
Milliliters. It's less than a liter. It's milliliters. Any questions? Yes.
Calculate tidal volume, are you gonna ask the minimum or the maximum, or just no, you just?
I will ask you in minimum, I will ask you maximum, and I will say in kilograms, or I will say in pounds. Yes. Okay, any questions with that? Now that's one breath. We dealt just with one breath, right? We talked about a tidal volume. How much air, how much amount air a patient inhales and exhales every breath. Now if you just look at the definition of a tidal volume, you can see it's a difference between ventilation and oxygenation. Why? We ventilate, but all of that tidal volume is not involved in external respiration. The part of that tidal volume that's involved in external respiration is called alveolar ventilation. And the rest of it is dead space. And why do we have dead space? So that our airways and lungs won't collapse on expiration. Does that make sense? Okay, as therapists, we understand this. Now, when patients have diseases, that dead space increases, and then we call that physiological dead space, but we'll deal with that next semester. That's something else different. All right, now back to minute ventilation. Why are we concerned about minute ventilation? Well, we want to know what a patient is moving per breath, and then we want to know what a patient is moving in a minute, right? So, you all gave me the wonderful formula, tidal volume times respiratory rate is minute ventilation, right?
Yes.
That's minute ventilation. But you realize, just based on the tidal volume, even though a patient may have a minute ventilation of whatever, all of it's not involved in gas exchange, right? Because if if all of a tidal volume is not involved in gas exchange per breath, certainly all of the tidal volumes is not involved in gas exchange in a minute. Does that make sense?
Mm-hmm.
So when we talk about minute ventilation, we're just talking about how much air the patient moves. As far as ventilation, it doesn't have anything to do with oxygenation, right? All right. So that's on exhalation. The E stands for exhalation, and I never figured out how to do it on PowerPoint. There is a way, but I never bothered with it. It's minute, there's your dot. So this should have a little dot up here so you can put it on your PowerPoint. Minute ventilation. So if we want to calculate, back to high gas flow systems, if we want to guesstimate, and it's not necessarily accurate, but it'll put us in the ballpark. If we want to know what a patient's inspiratory demand is or their flow is, we need to take their tidal volume and multiply it by their respiratory rate and get minute ventilation. And we know how to do that, right? Then multiply it by 3. And that'll give us V dot I, which is inspiratory flow. And that too has a dot on it, and I couldn't do it. So this is minute ventilation, and this is inspiratory flow. This is how much they're inhaling, or I'm sorry, not how much inhaling, but the time it takes to inhale, and this is the amount that they exhale. This is on inspiration, this is on expiration. Okay, V dot I is flow, this. Inspiratory demand, inspiratory flow. And this is minute ventilation, and we just went through those parts. Right? So let me repeat. Tidal volume consists of 2 parts. About 1/3 is anatomical dead space. The part of the tidal volume that's not involved in gas exchange. What purpose does it serve? It's sitting in the airway on expiration, and it keeps our alveoli and airway open. Make sense? And it's full of what?
Nitrogen.
It's full of what? It's on expiration.
CO2.
Full of
CO2.
CO2. Anatomical dead space is full of CO2. So the next breath, when we exhale, that's what we're going to exhale. So let's talk about the partial rebreather. When a patient rebreathes their own CO2, they're really rebreathing their own anatomical dead space. Does that make sense? Okay. All right. Okay, so one part of the tidal volume is not involved in gas exchange, and that's anatomical dead space. 2/3 of the tidal volume that is involved in gas exchange or external respiration is called alveolar ventilation. Any questions with that? Yes.
When you say that it's full of CO2, that anatomical dead space, is that still contained the same amount of nitrogen? Because I know it's holding the lungs open, and it's holding the alveolar.
Ventilation doesn't have anything to do with nitrogen. Ventilation has to do with air moving in and out, and we're concerned primarily because of the ventilatory drive, carbon dioxide. Nitrogen is stability for oxygen on inspiration.
But it has nothing to do with,
I'm talking about expiration, dead space. Okay? All right, don't have anything to do with it.
okay.
All right. Any questions with that? All right, so you got two parts of a tidal volume. Know what they are, 1/3 and 2/3. One part is not involved in gas exchange, 2/3 is. Take your tidal volume times your respiratory rate and you get a minute ventilation. What's the, not formula, what's the definition for minute ventilation? I didn't hear you.
Tidal volume times
I didn't ask for formula. I wanted definition.
How many breaths per minute?
What it?
The air that you take in and out in one breath.
Minute ventilation.
1 minute.
respirator.
The amount of air inhaled and exhaled in 1 minute. We're not going to guess at this. We know the amount of air inhaled and exhaled in 1 minute. That's important. The amount of air a patient inhales and exhales in 1 minute. And what's the normal number for minute ventilation? What's normal value? 4 to 8 liters per minute. 4 to 8 liters per minute. That's normal. May not be normal for everybody, but we kind of put everybody in the same category. Make sense? All right. So if a patient has, write this down, a patient has a tidal volume of 500 milliliters, and they have a respiratory rate of 12 breaths per minute. What's their minute ventilation? Look right up here. Oh, I'm sorry, I don't have it up here. You just wrote it down. Tidal volume times respiratory rate. What's the minute ventilation? 6 liters per minute. Good. Very good. Everybody get that? Yes.
When you said inspiratory flow,
Inspiratory flow.
is that the time that you inhale?
Yeah, that's inspiratory flow. Any other questions? All right. So we have a patient who has a tidal volume of 500 milliliters, and we counted their respiratory rate, and this patient is breathing 12 times per minute. So we've just calculated the what? Minute ventilation, right?
Yes.
All right. Everybody got that? Yes.
What unit is inspiratory flow then?
Liters per minute. It's inspiratory demand, inspiratory flow. Everybody got that, right?
Yes.
Now let's find the inspiratory demand. Yes.
I'm just curious, why is it minute ventilation times 3? Is there a specific why it's times 3?
Yeah, because it'll put you in the ballpark of the flow. Flow is always 3 times greater than the minute ventilation. Yeah. All right. So now we got 6 liters per minute. Any questions? Now we want to know what is the patient's inspiratory demand. What is it? 18 liters per minute. Okay. So this is saying, I'm going back to a high gas flow system now. Whatever we put the patient on, the inspiratory demand or the total flow of that apparatus, that device, should provide 18 liters per minute or more. Everybody understand that? In this particular case, it's going to vary. I gave you a tidal volume of 500, and I gave you a respiratory rate of 12. And so based on that tidal volume and rate of 12, we calculated the patient's minute ventilation to be 6 liters per minute. You take the 6 liters per minute, and we multiplied it by 3. Now we got an inspiratory demand of 18. Got it? Now let's say it's this asthmatic, and this asthmatic's inspiratory demand has now increased to 30 liters per minute because they're experiencing bronchospasms. whatever type of device we put them on, if it's a high gas flow system, it needs to be able to achieve that 30 liters per minute or higher. Okay? So the whole thing about a high gas flow system, the total flow coming from that single apparatus meets and or exceeds the patient's inspiratory demand.
Okay.
That's the whole thing. And it can deliver a specific FiO2. A low gas flow system can. Okay? Any questions with that? Now, you guys, and I know you need to know the math. The math is fine, but you need to know the definitions. When I ask for a definition, don't give me a math formula. That's not a definition. That's a formula. And what good is being able to do the math and then you don't know what the numbers mean when you do the math? Does that make sense?
Absolutely.
It's very, very important that you can articulate what a minute ventilation is, because that's what respiratory therapists do. It's very important that you can articulate it's 2 parts of a tidal volume. We know that. Does anybody else care? No. Nobody else cares but a pulmonologist and us. But this is our area of specialty. Anything to do with breathing. We understand it. We got it. Okay? So if you need to go back and review Chapter 2 in cardiopulmonary ventilation, tidal volume is in there, anatomical dead, and I know it's in Egan's, I don't know where. Anatomical dead space is in there, effective or alveolar ventilation is in there. You all said, oh yeah, 3 to 4 if you're using pounds, 5 to 7 if you're using kilograms. But anatomical dead space is always 1 cc or 1 ml per pound of body weight. So if you are in kilograms, you got to convert that to get anatomical dead space. Okay? Any questions with that?
I think I know. Sorry. I got confused because I was trying to, anatomical dead space is going to be different than alveolar.
Absolutely.
Okay.
Anatomical dead space and alveolar ventilation together equal your tidal volume.
Okay. I was somehow crossing wires there. Thank you.
Okay. Yeah, both of them equal your tidal volume. Both parts make up a tidal volume. Okay. So minute ventilation is how much we move in and out per minute, right?
Right.
And how do we get flow? We take the minute ventilation and multiply it by 3. And the whole purpose of a high gas flow system, it can meet or exceed a patient's inspiratory demand and deliver a specific FiO2, right? Okay. All right. So low gas flow systems deliver a variable FiO2, whereas a high gas flow system will deliver a specific FiO2. So you know the range for a nasal cannula, right? And its liter flow.
Right.
You know the range for a simple mask and its liter flow, right? All right, Letitia, each one of these that I'm calling are devices or apparatuses, all right? You know the range for a partial rebreathing mask. What kind of patient do we put on a partial rebreathing mask? One in respiratory insufficiency. Very good. All right. And then you know the liter range and FiO2 for a non-rebreather, right?
Yeah.
And we have a range, but how much oxygen the patient actually gets depends upon their what?
Minute
And the formula for minute ventilation is what? Tidal volume times respiratory rate. What are the 2 parts of a tidal volume? One is
Anatomical
dead space. And what purpose
alveolar.
does anatomical dead space serve? All right. And it's full of?
CO2.
Good. And the second part of a tidal volume is what? And what does alveolar ventilation do? Directly involved in gas exchange or external respiration. Got it? Woo! Got through it. Okay. Then the minute ventilation, what's the formula for minute ventilation? Formula for minute ventilation. Tidal volume times respiratory rate. All right. And then how do we calculate inspiratory flow demand? Minute ventilation times 3. Okay. And why are we concerned about an inspiratory demand? Because if we decide to put them on a high gas flow system, we know that high gas flow system can meet that demand or exceed it, right? Plus a bonus, deliver a specific FiO2. Any questions? We haven't talked about how it delivers, but I guarantee you it will. Any questions? Yes?
What is the minimum flow for a high gas flow system?
That depends. It depends what you're using.
Okay.
It depends.
But can a high flow system start off at 1 liter per minute? Or do you have to start off at a minimum of maybe 3 or 4?
It depends on what it is. Okay. Once we get there, maybe it'll answer your question.
Okay.
Okay. It depends on what it is. Okay. Okay, deliver a specific FiO2. Examples. 28%, that's specific. It could be 24% too. I don't have it on there. 32%, 35%, 40, 50, 60%, those are specific FiO2s. Meaning if we put the patient on a 24% Venturi mask, we know the patient is going to get 24%. Okay, so now let me interject. You've learned about this CO2 retainer, right? Mm-hmm. And we know we can put them on a nasal cannula, but what's the highest liter flow we can go? 1 to 2. 1 to 2. 2 liters per minute. And why? Why would it be dangerous to put them on the CO2 retainer? Knock out his hypoxic drive, his or her hypoxic drive, right?
Yes.
Okay. So, if we decide, or if we do put a patient, a CO2 retainer, on a nasal cannula at 1 to 2 liters per minute, and it's not sufficing, or we're not seeing what we want to see as far as the PO2 and the SaO2, we know we can't go any higher with a nasal cannula because it's a low gas flow system and the FiO2 will be variable. We then go to a high gas flow system such as a Venturi mask and put a CO2 retainer on a specific FiO2, whether it be 24% or 28%. It's guaranteed that they'll get no more. Write it down. So what I'm saying is that you can put your CO2 retainer on a nasal cannula 1 to 2 liters per minute. You can. But if you don't see the results that you want to see, you put them on a high gas flow system, specifically a Venturi mask. Have you all seen the Venturi mask in lab?
Yes.
Okay, then I don't have to go through it. It is a high gas flow system, and it delivers a specific FiO2.
And that's the only one.
Absolutely not. I'm just giving you a CO2 retainer. Absolutely not. Nope.
Would you want to go above 28%?
It depends on what their blood gases are.
Okay.
It depends.
So you said CO2 retainer cannot Venturi mask?
Yes.
1 to 2 liters per minute?
No, Venturi mask delivers specific FiO2.
It's like 24
You got to
28%.
choose what FiO2 you want them on. More than likely, it'd be 24, 28%.
Say 28 would be the base, right?
Now, I'm not saying that you can't put a CO2 retainer on 32%. I'm not saying that. You just have to know what their PO2 is to make that call. Everybody understand that?
Yes.
Yes.
So, if you have a scenario, whether it specifically tells you it's a CO2 retainer, or if your scenario says that it's oxygen-induced hypoventilation, what does that mean to you? That's still a CO2 retainer. If you have to choose between a non-rebreathing mask at 15 liters per minute, a simple mask at 8 liters per minute, or a Venturi mask at 24%, what would you choose? At 24%, because you can control that FiO2. If you use the simple mask or the non-rebreathing mask, you don't know what the patient is going to get, and for sure we know eventually we'll knock out the hypoxic drive, right?
Right.
So your choice for CO2 retainer, yes, the nasal cannula 1 to 2 liters per minute, and or a Venturi mask. Always. Now you can put non-CO2 retainers on a simple mask or non-rebreather, but not CO2 retainers. And for this, we are controlling the total flow to the patient, but more specifically, we're delivering a specific FiO2. Okay? That's the whole concept of a CO2 retainer being on a Venturi mask. We know what the FiO2 is. We know that it's not variable. Okay? So you can have a physician that writes an order. Let's say it's a medical student. Oh, God, only a medical student, but hopefully not. But it could be an intern or whomever. And you know that the patient is a CO2 retainer, and because you're the therapist, and this intern, whomever, doesn't know. And perhaps he or she may write an order, nasal cannula at 6 liters per minute, or simple mask at 5-6 liters per minute. You don't do it, because you know this is a CO2 retainer, and you know that this patient is breathing off their hypoxic drive. You understand central chemoreceptors are knocked out, right?
Yes.
And you understand it would be more beneficial to put the patient on a 24 or 28% Venturi mask as opposed to the low gas flow systems. Because that Venturi mask is going to guarantee what you set it up at. Any questions? Now, CO2 retainers are not the only type of patients that we use Venturi mask on, but we definitely want to use it on a CO2 retainer. Okay? So high gas flow systems, again, meet and exceed the patient's inspiratory demand. How will you know what the patient's inspiratory demand is? Take the minute ventilation, multiply it by 3. How are you going to know the minute ventilation? You get the patient's tidal volume, you count their respiratory rate, do that math, and multiply it by 3. Then you know what you're in the ballpark dealing with. Okay? Anytime, and just associate so you can have a picture in your mind, anytime you have a patient that has an increased work of breathing, they're going to have an increased inspiratory demand. But that doesn't mean all of them will go on a high gas flow system. Everybody understand what I'm saying? Let's take the asthmatic. Asthmatic is experiencing bronchospasms, and they're short of breath. I'm not going to let you put a mask on me. I'm too short of breath. Just give me the nasal cannula and give me my bronchodilator, and hopefully things will be resolved. But some patients will need a higher FiO2. But if you want it to be specific, then you got to use a high gas flow system. Okay, so it depends on your choices. It depends on what's going on. But that CO2 retainer, rule, nasal cannula 1 to 2 liters per minute, or go to a Venturi mask. That's a must. Because if not, you're going to knock out their hypoxic drive dealing with low gas flow systems. Any questions? Okay. Now, you have a Venturi mask. Also, there it is, large volume nebulizer. That's a high gas flow system. But what else does a large volume nebulizer do? Humidity. So when you use a large volume nebulizer, it is a high gas flow system, and it can deliver a specific FiO2, but it delivers high humidity as well. So you see why we wouldn't want to use that on a CO2 retainer? We just want to give them oxygen. If you just want to administer oxygen, your choice is the Venturi mask. Make sense? But then if you have to add some humidity, then you use a large volume nebulizer. So a large volume nebulizer, you can look on it, and I'm sure you've seen it. Has specific FiO2s on it, because it's a high gas flow system. So you have to know when to use your equipment. Both a large volume nebulizer and a Venturi mask are high gas flow systems. A Venturi mask is for oxygen administration only, a specific FiO2. A large volume nebulizer will deliver a specific FiO2 as well as high humidity. So you have to know when to use appropriate equipment. That's why you're in lab. Everybody knew that, right? Because I know you guys are a little ahead in lab as opposed. But nevertheless, this and a Venturi mask both are high gas flow systems. They meet and exceed the patient's inspiratory demand, and they both deliver specific FiO2s. Okay? All right. Yes?
So I just want to make sure, so Venturi mask is the only high flow gas system that does not need to use humidity? Or can they all have that variable? Because I thought they all had to use humidity.
A Venturi mask doesn't require humidity. No. So yes. Yeah. Everything else, mechanical ventilation, CPAP and all that, it's in the machine. Okay, so everybody understand the difference between a high gas flow system and a low gas flow system? This is rudimentary respiratory care. We know our equipment, we know patients. And then therefore, based on patient need, we can select the appropriate equipment. Because right now you're learning, but you're going to have to start making decisions on what to administer to your patient based on blood gases and how the patient presents. Okay, here's Bernoulli's principle and Venturi's effect. That's called a sigh, and you're going to do a lot of it, but it's good for your microatelectic alveoli. It opens them up. Okay, HAFO, high, air, oxygen, enrichment. High airflow, oxygen enrichment. High airflow, oxygen enrichment, HAFO. Also called air entrainment mask, AEM. So when you see air entrainment mask, you know that's a Venturi mask. Air entrainment, and so I'm going to explain it. Any questions on that first bullet? It's all there. Bernoulli, I don't know if he was Dr. Bernoulli, physicist Bernoulli, in his honor, like Torricelli. He came up with millimeters of mercury, so they call it Tor. You know, come up with something, they may name it after you. All right, Bernoulli. Bernoulli says, given a tube, you got a tube, not the airway now, I'm not speaking of the airway. Given a tube, and let me find my little Venturi devices. All of you got a Venturi mask in your equipment bag, right?
Yes.
Yes.
Cool beans. I saw some colored ones over here the other day. Well, here's plenty of non-colored ones, but I wanted the colored ones. Well, for lack of time, I'll find it. Here's a tube. Bernoulli said, here's a tube. Here's your tube. All right. He says, given a tube and at the point of constriction, meaning restricted flow. So if we look at, if you will, this is a tube. At the point of constriction, it means one opening of the tube has to be smaller than the other opening. So the tube is wide when we start and it gets narrow. That's what he's saying. Everybody with me? Yeah. So at the point where it gets narrow, that's the point of constriction. Everybody understand that? I think I have a diagram, and it's definitely one in Egan's. Yeah, here you go. This is Bernoulli, and here's the tube. And this is the point of constriction. This is Bernoulli. Okay, I'll go back. So Bernoulli says, given a tube at the point of constriction, another gas can be added to the point. So Bernoulli is saying, let me go back to the diagram. This is Bernoulli from here to here, and he's saying where this tube is constricted, more gas can be added. Venturi says Bernoulli is absolutely right. And because more gas can be added, what Venturi is saying, we can control total flow and we can control the FiO2. So together with Bernoulli's principle and Venturi's effect, we have what's called HAFO, high airflow oxygen enrichment. This is the reason a high gas flow system meets and exceeds the patient's inspiratory demand, because all of the flow comes directly from, if you will, the Venturi mass that the patient is going to inhale. And then because this can be entrained, this is going to be, imagine this is going to be your oxygen source coming from your 50 psi source, right? Okay, this is the 100% oxygen. But this is going to be additional air, but the air is not going to be dependent upon the patient's minute ventilation. The air is going to be drawn from the room air and be mixed with this oxygen. And so by the time it gets to the patient, it's a specific FiO2. So flow and oxygen are together at this point of constriction. That's Bernoulli's principle and Venturi's effect, why we can deliver specific FiO2s and why the total flow can be controlled in an apparatus as such. So if we have a patient, we did 6 liters per minute ventilation times 3, 18 liters per minute. Whatever we set this patient up on, we need to make sure that the flow is at least 18 liters per minute and can exceed that, and then whatever FiO2 we need. So specific FiO2s are based upon Bernoulli's principle and Venturi's effect. All right? So, does anybody, I saw somebody had one of these out. Does anybody happen to have their Venturi mask with them? Don't worry about it. Don't go. I want to see if I can find another. I want to show 20. And I just looked in here on Friday with the high school students, and I said, oh, they're right here. This is what I need, and here they are now, and I don't have it. I need to show you 2 of them. Ah, here it is. Here it is. This is the point that I wanted to make. Okay. I'm going to take this off just to show you. Okay. Both of these are Venturi devices. All right? Both of these, you call them Venturi devices with Bernoulli's principle. One is white and one is blue. But what with these masks, the green, it delivers from 24 to 30%. And on here, which is really cool, it tells you for 24 and 26% use a flow of 3 liters per minute. And then it tells you for 28 and 30% use a flow of 6 liters per minute. It's right here. It tells you. You don't have to figure it out. Just read. Okay. On this one, same thing, but I have it, the white adapter, and you see this is kind of written in green, but can you see the white? Okay, on the white side, a little higher FiO2. Here's 35%, and it tells you to set it at 9 liters per minute. Then if I wanted it at 40 or 50, it tells you 40% set it at 12 liters per minute, and at 50% set it at 15 liters per minute. Everybody see it? I'll pass these around. Okay? All right, so now let's look at this. We know 100% oxygen is coming out of the wall. How can these things deliver, these apparatuses, this principle, deliver specific FiO2s? Because if we look at these ports, and I'll see if I can get this off. Yeah. I wanted the color ones though, because they are really, really good, and I didn't move them. All right. Okay, both of the tubes have the same size orifice here. Everybody see that? Yes. Okay. Now, look on the inside. See the differences in the orifices? the openings, I don't know if everybody can see it, I can pass it around. Which one has the greatest constriction?
Green.
The green.
The green, right? So at the point of the greatest constriction, more room air can flow in. So this is the apparatuses that delivers the 24%, the 26%, up to 30%. This orifice, although it is constricted compared to this orifice, comparing it to this, has a larger constriction, if you will, or the constriction is not as large, I should say. So this delivers a higher FiO2. This device is the one that will deliver 35, 40, and 50. So what am I saying? I'm saying the greater the room air entrainment, the lower the FiO2. Write it down. The greater the room air entrainment, the lower the FiO2. Just like with minute ventilation, more minute ventilation, the lower the FiO2. But now we're not dependent upon minute ventilation. We're dependent upon flow coming through this little itty-bitty device. This right here, without this, you have no Venturi mask. Now, they come with every Venturi mask. But this is a Venturi. This is what makes this a Venturi. Here's Bernoulli's principle from this point to this point. And then you can see the difference between these. So you as a therapist, let's say these values weren't on the tube, just you as a therapist, if I showed you this, you should be able to tell me which one of these will deliver the highest FiO2. I may not ask you what FiO2, but which one will give me the higher FiO2. And the one with the largest orifice will give the higher FiO2. Because it'll take in less room air, this one. If I asked you which one will give me the lowest FiO2, you'll tell me this one because it takes in what? More room air. And I'm going to pass these around so you can see them. Look at them very closely. And so when we're talking about a point of constriction, that's the point of constriction. See the difference? Makes a big difference. So we don't have to even figure out the liter flow. All that's been calculated. But that's how Venturi. And so even with our mechanical ventilators, anything that delivers, if we can crank up and dial in 90% oxygen, 60% oxygen, it must have a Venturi effect in it. And it is a high airflow oxygen enrichment because you got a combination of oxygen and air in a total flow. And it's controlled by that little fellow right there. Yes.
So the intake ports, that's talking about where the air entrainment comes.
Yes, the air entrainment.
Not the hole that FiO2 comes through.
The FiO2, it's not called hole, orifice. The orifice that the oxygen comes through would be, whether it be a tank or a disc or piss, whatever.
Yeah.
Okay, but that point where, at that small point, that's where the room air is entrained. And that determines the FiO2. Okay. The more room air entrained, the lower the FiO2. The less room in air entrained, the higher the FiO2. Does that make sense?
Yes.
Okay. That's Venturi's effect and Bernoulli's principle. I want you to take a look at it.
O-R-F-I-C-E.
Okay, it's driving me nuts because I know it, but you know how it goes out of your mind. I'm like, thanks.
There was a little bag with Venturi's in it, and they were different colors.
We have them in our kits.
Here they are. Here they are. Ah, found them. This is what I wanted you to see. Now, this is a company. I saved these. This is a company. The company that you, or the Venturis that you have, just come in two different colors, green and white. This is a company that manufactures them in different colors. And what's really great, all you got to do is just read. Each one represents a different FiO2, but I want to show you the difference. Okay, I'm going to pass these around, and you're going to see 3 different points of constriction. And based on the point of constriction, I want you to be able to determine, we're not going to talk about specifically what the FiO2 is, but I want you to be able to look and say it's a higher FiO2 or lower FiO2. Where are the other 2? Oh, okay, so look at these 3 different points of constriction. Here, and I'll pass these over here so you can see. Ah, yeah, I can see the difference. Okay. Look at the 3 points. Okay. And can you look at it and tell which one would be the lowest FiO2 and which one would be the highest FiO2? The one with the smallest diameter is your lowest FiO2 because it's going to entrain more room air. Respiratory therapists know your equipment. You have to know your equipment. And then when you take your boards, they're not going to ask you this. They're going to ask you how you troubleshoot it. But I'm going to show you how to troubleshoot it, but you can't troubleshoot it until you understand the principles. So while that's going around, are there any questions on Bernoulli's principle and Venturi's effect? How are our apparatuses able to deliver specific FiO2s? It has to have a Venturi effect in it. Room air is entrained along with the oxygen that meets and exceeds the patient's inspiratory demand, by definition, is a high gas flow system. Can everybody see as we're passing it around? Okay, yes.
So the smaller the orifice on one of the Venturi masks, I guess, the more room air can
The
come
lower the
in.
FiO2.
The lower
Because
the
it's
FiO2.
more room air is entrained.
Okay.
Yeah. Yes, ma'am. All right. Okay, let's do this one. Pass the gas. Look at your, while we're moving on, this is called pass the gas. That doesn't mean fart. That doesn't mean poop. Let's look at this. We got a 68-year-old male patient has had COPD for many years, and he's admitted for an acute episode of dyspnea. ABG on room air. His PO2 is 44, and his SAT is 84. So what is that telling you right there?
CO2 retainer.
He's a CO2 retainer, and he is breathing off this hypoxic drive. Okay. Which of the following is appropriate to deliver oxygen therapy to the patient? It's the next slide. I couldn't put it all on one side. This is how you put stuff together. Do we give them a 28% Venturi mask? Do we give them a non-rebreathing mask at 10 to 12 liters per minute? Do we give them a nasal cannula at 5 liters per minute? Do we give them a simple mask at 8 liters per minute? And
I say A.
every answer you select, you have to
Venturi
explain
mask.
your rationale. A. Okay? So what you know about a CO2 retainer. You know a little something about blood gases, and now you're learning about oxygen therapy, and this is how it all works, and you have to make a decision. Now, if you didn't know what a CO2 retainer was, if you didn't know what central chemoreceptors were, if you didn't know what a hypoxic drive was, if you didn't know anything about blood gases, you couldn't make a call here, could you?
No.
See how much you've learned? This is respiratory care here. This is a simple board question. So the correct answer is A. Why? Because we know A is a high gas flow system and it delivers a specific FiO2. Any questions with that? Right now, what I've been doing all week, and I'm not going to do it until we finish Module 2. So far, I've come up with 21 questions. I think I'll just add 4. But after we finish the module, I have some questions that I'm going to give you guys. When I say give you, we're going to do them here in class.
Oh, okay.
We're going to do them right here in class, and some of them are actual board questions to get you going, to see what you need to know.
Okay.
Because right now, it seems like every day I'm losing some of you, but if you plan to practice respiratory care, you got to know this, and I make no apology. I had to learn it too. You've got to be able to pass your boards, and then if you're right there in front of a patient or a physician has an order, you've got to be able to make a right decision. Not all physicians, but some are going to depend on your expertise, and you've got to be able to explain to them what you're talking about, or you're going to look real foolish. Okay? All right, any questions about those Venturis that's being passed around? All right. Okay, so based on that scenario, but you had the PowerPoints in front of you, which of the following terms is correct? Is the patient in respiratory acidosis? Even though we don't have a PCO2 and we don't have a pH, we know he's a CO2 retainer. Right?
Yeah.
So is he in here respiratory acidosis?
Yes.
Yes. Okay, is this patient experiencing ventilatory failure with hypoxemia?
Yes.
Yes.
All right. Is this patient experiencing respiratory failure?
Yes.
Yeah, you bet your sweet Bippy. If we know he's a CO2 retainer, we know his CO2 is higher than 50, and then we had a PO2 of 44, right?
Mm-hmm.
Does it make sense?
Yep.
See, this is how we put stuff together. We know when we see it. Is the patient dealing with chronic hypercapnia with hypoxemia?
Yes.
Sure is. Is the patient dealing with respiratory insufficiency?
Yeah.
Not at all. Wrong answer. Okay. Is the patient dealing with respiratory alkalosis with hypoxemia?
No.
Not at all. Is the patient dealing with decreased minute ventilation with hypoxemia?
Yes.
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 Okay. Any questions? Yes.
How are we knowing that it's chronic?
Because the patient has had COPD for a long
I
period of
I
time.
see now. I'm going, but I have no pH, so I don't know.
See how we put things together?
Yeah.
Long period of time, he's chronic. And he's got a PO2 of 44, we'd be near dead. He's CO2 retainer. I could have put in there that the patient has had, I didn't even have to put how long, but I could have said the same thing and said the patient has smoked 1 pack of cigarettes for the past 30 years every day. CO2 retainer. I can add little things like that, but I just wanted to make it simple. So we've taken blood gases, synonymous terms of blood gases. We've taken central chemoreceptors, peripheral chemoreceptors, and oxygen therapy and just combined it in one condition. How about that? That's what we've done for the past 5 weeks. It's taken us this long to get here, but you understand, right? All right. Now, on the slide before, we could have put the individual on a nasal cannula, but you know what? He had a PO2 of 44. I don't know if I would want to put him on a nasal cannula at 1 to 2 liters per minute. I don't even know if I would want to put that patient on 24% Venturi mask. I'd give it a shot at 28 right now and see where he is and then assess him and then maybe have to lower it. Because it was so low, yes.
If you did something like that, would you have to keep, checking his PaO2
You must.
frequently?
You must.
Because what if it gets up to 61?
You must.
How quickly will they be?
When I say we, non-CO2 retainers will respond to oxygen in less than 2 minutes. You can put a patient on oxygen, and if you have them on a pulse ox, you'll see it rise. COPD patients, because they always have shunting, it's going to take them about 20 minutes. So if you put a CO2 retainer on oxygen, you need to wait about 30 minutes before you do a blood gas.
But you have to keep checking frequently after that.
You have
so
to.
PaO2 doesn't.
That's called patient assessment. You must. Because even though you're given 24% of 28, you want to see how effective it is. We certainly don't want it to be too effective and we still knock out that hypoxic drive. Right? Right. Okay. Any questions on anything we've covered so far? So high gas flow systems meet and exceed your patient's inspiratory demand. How? Why? Because of Bernoulli and Venturi. And Venturi says we can also deliver a specific FiO2. Okay? So we went through tidal volume today, the two parts of a tidal volume. We've done minute ventilation. Yes?
Yeah.
And we've done inspiratory demand. Yes? And you know definitions for those. Yes?
Mm.
All right. And so fundamentally, we've gone through what is a high gas flow system. It's capable of doing two things. Meeting and exceeding the patient's inspiratory demand. That's in reference to flow. And then it can deliver a specific FiO2 based on Venturi. Yes?
Yes.
And then we've taken blood gases and the PO2 and combined it and came up with the answer for passing the gas. Any questions? It's more to come. All right. And we'll wait till Monday and I will start how we calculate flow. 3 parts air, 1 part oxygen. What's the FiO2? We'll learn all that. I'll wait. So what I want you to do is pull out your Egan's workbook, and you all should have your part 2 of chapter 1 for me today.